Yo, welcome to the Table Talk podcast, where we sit down, pull up a chair, and we get started. This podcast is designed to provide you packed full of information to help you with your training, nutrition, lifestyle, and well-being, where we interview myself through case studies to give you lifetime experience. And then we also interview high-performing individuals or other career-focused people who are looking to make changes in their lifestyle, training, nutrition, and well-being. So let's pull up that chair and let's go. Yo, welcome to Table Talk. Today we are here with special guest Luke Ross, gentleman who I met a long time ago getting a massage and treatment, where I, as a massage therapist, believe, you got to apply force to make change. And he's a man who's read lots of the research. He actually has a master's in research. Yes, he's the master of research. Currently completing a PhD. And knowing him, it will probably be more to come, because this man loves what he does. In the massage, he literally did this. If you're listening, imagine a subtle stroke on your muscle. Any muscle. Not that muscle, people. Come on. Get your head out of the gutter. But it was actually on my tips, because they were really tight. And it was like, dude, why are you stroking my tib? Release it. He's like, I am. And it really changed my perspective of how I think and treat with my clients, because he informed me about all the research that's out there. He also did test me and go, have you read all the research? Do you have a master's of research? But it came from a place of love and care. And since then, has opened my eyes to other treatments, techniques to help more people with their training, nutrition, their lifestyle. And I'm really excited to have him come on today to actually share his view in an area that he wants to specialize in, which is more the female hormonal cycle, and being able to help more people, more women especially, get out of pain in their menstrual cycle. So Luke, welcome.
So the interesting thing with the massage thing, right, is, and that feeds into sort of my practice approach, is it's not really about whether or not it's hard or soft. It's about what the patient perceives to be beneficial. And a lot of investigation into testing and all this sort of stuff, especially now, and treatment, is more about patient perception of benefit, which is why placebo is a thing, and you will get results from a placebo. It should not have a mechanism of effect, but it does, because people think it does.
Would that be why you start soft? Because once you go hard, it's hard to go back to soft, where if you start soft, you can build on it?
100%. And that's the same with adjusting as well. So I'll always start a bit softer. So yeah, it's actually a research interest of mine to get to eventually, which is to sort of investigate forces when it comes to, particularly with adjusting. So chiro is kind of main tool, but whether or not lower and higher adjustment forces can achieve the same outcomes, which we kind of believe and have seen clinically, but that doesn't constitute proper evidence. So
yeah, wow, cool.
I think so.
And Luke, what before we dive into the hormone section, what drove you? Well, best way to say it is, how did you start into the field of chiropractics, into them research, and that what's then led you towards understanding more the female cycle and what's going on with their bodies?
Cool. So if you thought the intro was long, this might be worth. So my initial interest in just the human body actually came from the TV show House MD. There was, in one of the early episodes, a kid who his leg kept flicking at random. House identified it as a myoclonic jerk or reflex, which he described as the body. So I'm sure a lot of people have experienced it, where you're sort of dozing off and you kind of shake awake, or like your hand twitches and it wakes you up. That's what he was describing. So a myoclonic jerk is the brain interpreting you falling asleep as you dying, so it sends a random fire of neurons to wake you back up. Now, in hindsight, I don't think that's 100% the correct definition. I've looked it up years ago, but now I don't remember. So don't quote House on that. But nonetheless, it really spurred my interest. I thought the body is just really, really cool. So from there, I thought about doing medicine, but the logistics and the actual practice life of that weren't appealing to me. It seemed a little bit too heavy. So I went down the route of manual therapy, and I was looking at sort of entering a physio program. And then I went and saw a physiotherapist for an issue that I had. And I want to clarify, I'm not about to shame physiotherapists, but that practitioner was useless. Did none of the things that I would quantify as a basic requirement in a clinical interaction. So didn't explain the injury, didn't ask for consent for treatment, which consisted of a TENS machine, and then he left the room. But didn't give me any exercises, didn't give me any prevention, so just useless.
So the machine didn't help.
I don't know, because I still don't know what the injury was. I felt like a tweak in my shoulder, which at the time, like in hindsight, I just picked up a weight that was too heavy and didn't set my shoulder properly first.
Had a myoclonic jerk in your shoulder.
Yeah, like classic falling asleep as you pick up a dumbbell situation. Anyway, so at the time I thought that's what physio must be. And so I was like, oh, well, I don't really want to do that. A couple months later, I rolled my ankle and I went and saw a chiro that lived on my street. And he was really, really cool, really personable, really knowledgeable, told me what happened when I rolled my ankle and why re-injury is really common with a rolled ankle, and said you need to do balance work. And he lent me, he had a wobble board. So for those who don't know, it's generally a board with like a dome underneath, and it's hard to balance on. And he said, go home, take this, do these exercises every day, bring it back to me in 2 weeks. And it was just a really pleasant interaction. I don't think I have actually, I've rolled my ankle once since, and that was because of a hole in the pavement a few months ago. But for the most part, like, my ankles have been pretty good, which is largely because of the education he provided in that session. I was like, this is really cool. This is the sort of stuff that I kind of wanted to do. And from that, enrolled in chiro, and then just fell in love with it more and more. And then you'd said, why the interest in research? So it was less of an interest in research and more of a someone's got to do it kind of calling. So the teachers that I liked the most were researchers as well as clinicians, and that's sort of what I thought I could aspire to do. And they made it very clear that chiropractic is lacking in evidence compared to most health professions, and that's because most chiropractors want to get out there and help people, which I completely understand. So yeah, it was a thing of, I knew that not many, if any, people from my cohort were going to do it, so I put my hand up for it. And then, sorry, you said why the interest in female health in particular. So most of the significant females in my life have had a health issue that is related to gender-specific organs and hormones. So my mum had a pretty rough transition into menopause. Quite a few of my friends had had really nasty periods, and things like that. So we did an online seminar a couple of years ago where a female chiropractor talked about some really basic women's health stuff. And it was stuff that I had never heard through the entirety of my health degree, which was 5 years. I thought,
really? 5 years?
Yeah. Which is not me throwing shade at the uni. Being a teacher in that program now, I completely get that you can only fit so much into that 5 years, and then it's on you to go out and sort of find the interests that you want to look into further.
You had a foundation that you could build upon when you went from that seminar?
Yeah. And so that sort of made me think, like, gosh, there's a real lacking in women's health just across the board. And so that sparked an interest and lit a fire. And so we've done a couple of seminars since. I've read a couple of books on it. So in particular, there's a naturopath. I think she's based in Sydney now. Her name's Lara Brighton, and she's written 2 books called The Period Repair Manual and The Hormone Repair Manual, both of which are about natural and holistic approaches to helping women's health. And so, yeah, just now really driven to sort of get better messaging out there for female health.
Yeah, wow. So journey from injured yourself, not a great experience, to then self-care, going, wow, this is great. I'll be doing that, to then learning and then attending a seminar to obviously help the people around you, realizing there are gaps. So the next part is really cool that you've actually, feel a need. So you're now teaching and going, nah, most people, like I know in PT industry, they're like, the RTOs are terrible. It's like, yeah, but it's a foundational step for those that are really want to learn more, like yourself. Like I get it, good foundation. Now I'm building on it, so I'm going this way. Others go that way. Yeah. With on the female hormone cycle is I guess we'll go rapid fire with questions. So for someone listening what is a normal, like for females, what does normal look like? Or is there a benchmark that, like it's every 28 days? If it varies, is like that's okay? Like, are there certain questions or benchmarks for people to kind of check in with before they kind of go to someone or ask more questions?
Yeah. So 28 days is the accepted standard. Some fluctuation around that. So if it's a little bit shorter or a little bit longer is okay. More important is that it's consistent. So the turnaround is roughly the same each time. And I think that's largely to do with genetics, but there may be other things at play there that I just haven't come across yet. So timing-wise, that's what you're looking at. And then the thing that is the most fascinating, I find, is that it's generally accepted that painful periods are perfectly normal, and that suffering for 5 days is it's normal. You're bleeding, it's routine. But in the circles that I'm dealing with now, the accepted amount of pain is 2 out of 10 cramp on the first day, and that's about it. So for someone who describes their periods as painful, that's the first red flag for me. Contextually, red flag is usually a sign of something really severe, but in this context, I just mean that it's a flag that indicates that something may be wrong.
Yeah.
Beyond that, if you feel significant changes to mood that are sort of beyond your control, if you feel breast tenderness, if the flow is either really light or really, really heavy, and then, of course, significant pain, back pain, pain down the legs, painful intercourse, those sort of things, they're all indicators that something isn't as it should be. And a large amount of that is centered around hormone imbalance.
Okay. So should be a 2 out of 10. And if you are feeling or experiencing changes, could be a hormonal shift, which has taken time for that to happen. So it's not like feeling good, feeling good, feeling good. Oh no, it's an automatic shift. It's like something that builds up over time.
Yeah, so hormone imbalance doesn't sort of happen overnight. It does.
What?
Yeah.
I heard on TikTok it was.
Oh, well, TikTok said it. So with the 2 out of 10 pain, like my goal is always no pain, but a minimal amount of cramping that is relieved by either a heat pack or going out for a walk is acceptable. Anything that exceeds that is not, and it shouldn't last for a very long time. So hormone imbalance, there is also uterine position as a factor. So the uterus can either sit slightly more forward, so we call that anteverted, or slightly more posterior, we call that retroverted, which can impact pain and blood flow as well.
Does that happen? So different positions of the uterus, is that a genetic thing, or can that happen due to, like, I've had an accident, or over time posturally I've changed, and so therefore the body adapts that way?
So genetics would always play a role in this sort of stuff. The genetic component would be more about tissue laxity than anything else. Everybody's body kind of moves and shifts based on what we put it through. So posture would play a role. How much I couldn't tell you, but if someone had a really exaggerated lumbar curve, my logical thinking would be that it would push all of the organs slightly forward, and that would give you more of an antiverted positioning. Cool. So I'll start that thought again.
Yep.
So entering just before ovulation, where you've got the most estrogen in the body, there's a little bit of tissue laxity more so than through the rest of the cycle. So your organs may be more prone to shifting based on fascial tension that's happening through the body. So I think it's probably significantly multifactorial as to what causes those positions. And there isn't really a lot of research, if any, into that sort of stuff as of yet.
Okay. So somewhat of a predisposition for all of us based off how we're brought up. So I would say the cool thing for you is obviously you've been a chiropractor for years, so you have in-house experience. I know for me, like Kate, we had for years, there'd be every month, got to get the heat pack, got to get these drugs, got to get this, and have a big cast steel ball ready to go so she can throw up. And 3 o'clock, get ready to get the ambulance. Like, it's go time. The question here is, because people experience pain, you're saying it's hormonal, but how much is structural? Because I know when we met with your partner and Kate started getting adjusted regularly, she had misaligned pelvis, mild scoliosis, and she's been working on shifting, and we've adjusted her training to improve stability and structural integrity. So the chiropractic allowed us to assess the structure and quickly alleviate. Like, we were able, training and, your training nutrition over a spectrum can definitely help, but we were able to accelerate that. How, in your experience, often do you find people are misaligned in their bodies that leads to this?
So how common is misalignment, which is an interesting topic and sort of point of difference between clinicians and researchers.
Yeah.
Some would say that there is no such thing as misalignment and there's just tension imbalance. Some would say that there is, in fact, shifts in the pelvis and in vertebrae as they go up the spine. And I would say that the truth is probably a little bit of both. I definitely think and feel and clinically treat pelvises that are slightly askew, which the pelvis consists of 3 bones. You've got the 2 on the outside and then the bottom part of the spine. To me, it simply makes sense that you can get shearing this way. Largely in the physiotherapy world, they don't believe there's any movement at the sacroiliac joint, which is where those 2 side bits interact with the spine. They think that it's a fused joint. So most of them wouldn't agree that you can get motion through there.
But fascial tension and muscle tension would cause that. Yeah. Okay.
So, and I think that the research has kind of moved beyond that because, one, research hasn't really found structure to be significant, whereas clinicians do. And part of the concern in the research world is if you tell a patient that they're structurally misaligned or that their structure is wider than pain, that the patient will perceive that as the way I'm built means I have to be in pain.
Mm-hmm.
What it should actually be is a conversation around how the structure can be influenced and what you need to do to help not feel that pain. Because pain is so multifactored. Like, yes, structure plays a role, but it's a bunch of other things. Because you can get people who have terrible posture and don't look after themselves very well, and they don't have any pain whatsoever.
I know. Sons of guns. Sons of guns.
A lot of them are really, really young. I think when you are between the ages of sort of 14 and 20, you can get away with so much. But you still find people, and you see it on imaging, for example, their spines look like a bomb went off, but they're pain-free.
Yeah.
So that becomes a thing of their structure's shit, but their function's really good. And how the two interact is different for everybody. So that's where research doesn't always translate into practice super well, but we've got to have it there to inform our decisions.
Yeah. So probably to distill that, with all the experience that you have, the research, the seminars, it would be ill-advised for me to assume that just because I might have, I wake up and I feel like this, the misalignment is what's causing those disruptions. It's more like there's maybe your genetics, your nutrition, or stresses on the body, which can come from many other facets. They play probably more that has changed your hormones, which is possibly changed in how your body, like the pain and the function through those cycles.
So I was speaking just broadly about male and female health there, but also one of the links I realized I didn't tie together is what you pointed out. So nutrition and sleep and what sort of stuff you're doing, all of those things are more likely to have influenced a change in your structural presentation. So if you're not eating well, really highly stressed, dehydrated, you're going to be more tense, your muscles are going to be tighter. So if you've been working on the mouse all day and this is your mouse hand, slowly that shoulder's going to creep up. And then if that muscle's really tight, it might pull your head a little bit this way. And so that structure is a bit of a head shift, but it's not because you have a bent neck. It's a change in structure because of influences on the body. And that's just one particular possible scenario. So it's that thing of structure is important, but it's got to be part of a whole clinical picture.
Oh, so it depends. Oh, no cheat codes here. Outrageous. Well, then let's like I'd like to then test something in the sense of if we looked at a complete menstrual cycle then. So as we said, one thing you were saying that probably is a good benchmark is one thing, so probably to come back to where you started, which was a good benchmark is 0, like 2 out of 10 pain, heat pack, go for a walk, you feel better. But understanding that 28 days is a good benchmark, though subtle fluctuations as long as it's consistent is also okay. So someone who's maybe 33 days just purely on average, that's okay. But if it was 33, 21, 40, back to 28, then it's like something's going on.
So 33 is probably a little bit on the longer side. Fluctuations, or rather longer by 1 or 2 days, maybe 3 is kind of within the normal ranges. If longer than that, it would definitely be worth investigating if something is happening, because yes, it could be that something is out of whack, or it could just be that's your normal. Kind of like my blood pressure is consistently 140/80. Did all of the bloody tests under the sun, and they have no reason why it is that way. So they diagnose it as essential hypertension, which is stupid. Basically, it's just my normal is a little bit different because it doesn't fit the ranges that have been established.
Yeah.
So yes, a little bit of difference around 28 days is normal, but consistent is the key part there. If it's inconsistent, so it's 15 days, 40 days, those kind of things. One, it's probably not that you're having your period all over the shop. It's more likely to be mid-cycle bleeding, which is a problem and shouldn't be happening. But if it is in fact that your cycle is that short and then that long, then that's also not a good indicator. So either way, worth checking.
Mid-cycle bleeding?
So you can have bleeds outside of the typical day 1 to day 7, and that's what we'd call a mid-cycle bleed.
Okay. Is that during the ovulation phase?
So anything that's outside of that actual period phase, which is where you're shedding your uterine lining.
Yep.
Well, not yours, but
Rude.
yeah. So the actual period is when the lining of your uterus, which has been all prepped to house a baby, is discovered to not be needed. The body then goes, okay, cool, we don't need this, and so it sheds it, and that's what the bleed is. So if that is happening in much shorter, so if you're having that and then a week later you're bleeding again, it's less likely to be that you're having another period, more likely to be having a mid-cycle.
Is there a cause or correlation for what can happen?
Yeah, so there's a lot. So top of my head, endometriosis is probably one of the most common, because endo, you get bleeding all over the place. Endo's horrible.
Okay. So there's a list. How long is a period or a hormonal cycle?
So your standard or your average is 28 days, but it varies between 20 and 28 days.
Sorry, 20 and 20 years?
20 and 28 days.
Oh, okay. 30 years. Wow.
If it's 28 years, I think something may be wrong, or something may be very right. I don't know. Yeah, so 28 days, you will typically find that the luteal phase, so the phase after ovulation leading into the next period, is almost always 14 days. So that's the portion of the period that's fairly consistent. And then it's the period itself and the lead up to ovulation that can be a little bit shorter for some people. And if you're crazy out of that range, like if you're 35 days or if you're 10 days, which is not particularly common but can happen, that's where you probably seek some assistance. I dare say if your cycles are that sort of divergent, that there are probably some other symptoms happening as well, whether or not you're aware of them. So definitely worth investigating.
Okay. There's a current myth out at the moment that if you're at 33 to 35 days and you haven't menstruated yet, you should smell a menstruating woman's armpit. Have you heard of anything like?
No, have you done field research on this?
I have not. I have a client who has.
Interesting.
She's telling me about it, and I'm like, okay.
Yeah, interesting. Would be very curious. Not to smell someone's armpit, more as to the why. My guess is they're thinking it's like a pheromone thing.
It's getting as close as you can.
Yeah, interesting.
Is there much on pheromones that you could, I guess, an evil doctor or wizard, whichever way you want to go with that one, is like, could you release pheromones? Can you, like, if you're in a laboratory, create them to assist that? Or is it that's like the 1% thing?
So I'm not sure what pheromone impact on the cycle is. If anything, it's the opposite. So my understanding is the cycle influences pheromone production.
Yep.
What I do know, they did an interesting study, or they've done a couple of them, where it seems that women who are on the contraceptive pill aren't as responsive to pheromones, and they will typically be happier with a less attractive partner. So there was a discussion around, for women who are coming off of hormonal contraception, suddenly they're not as attracted to their other half because their interaction with pheromones has changed. And they did another study which tracked strippers who were on contraception, not on contraception, and the ones who were on contraception made less money. So yeah, go figure.
Huh.
Yeah.
Wow. We got brothels down the road. Do some experimentation. Oh, excuse me. Have you noticed a change in your financial situation? Yeah, wow, that's that's interesting. Because I know 6 years ago when Kate and I talked about the contraception, she came off. I noticed, not like game changing, but we did notice a change in obviously the way we could talk, communicate with each other for a period of time. Yeah, wow.
Yeah.
More you learn. Cool. With that information from the luteinizing hormone, estrogen, progesterone, are there, with the courses you've done, are there certain foods that people should be aware of at certain times?
So very broadly, yes, but it's less about food and more about the micronutrients of the food. So really common deficiencies, particularly for women, the big one is iron, which obviously they lose because they bleed once a month. So iron is a key component of hemoglobin. So heme means iron, and that is part of the blood that actually binds to oxygen and carries it throughout the body. So iron deficiency is really common, and that has a big impact. B12 has a really big impact. B6, zinc, and selenium. The specifics on that is probably too big for what we're doing today. We can always come back to it. So foods that are rich in those things can be a little bit harder on a plant-based diet. So good quality supplementation, if that's your life choice, like it is mine, is important. And getting it tested on a semi-regular basis. So I'd say at least once a year, if not more, if you have dramatic fluctuations.
Mm-hmm. And what about training? So micronutrients and nutrition, typically, the approach that I take is that when it comes to the end of their luteal phase, so coming into menstruation, we then look at what's known as a reactive deload. So we decrease the volume per exercise and also load, because obviously at that time, pelvic stability, there's more inflammation in the body. So they just have less stability or engagement.
Yeah.
If they want to keep sets up, cool, but make sure to bring volume load down so they can focus on control, more correctives to support their body. Because when it comes to training, it's a long game. No, get real strong in 12 weeks and then stop. It's like most people aren't doing that. Is there any, does that sound like a good strategy, or would there be more things to look out for and adjust?
So certainly being conscious of deloading is a great start, and it'll be a little bit different for everybody. So the key windows that are really sort of helpful to know for females when they're training. Oh, sorry, just need to shove this in. So the key windows, and I kind of discuss it as a traffic light system. So day 1 to 7, when the bleeding starts, is definitely more about focusing on recovery and gentle movement. It's not to say don't exercise, but day 1 to 7 is not when you're pushing it. It's not when you're going for PBs. Very much about checking in, listening to the body. As you said, higher inflammation, which is driven by the sudden loss of progesterone. So as you can see, progesterone drops as we enter the period. Progesterone is a lovely anti-inflammatory. So you've had all this anti-inflammatory and now it's gone away. So inflammatory is going to be a little bit higher at this stage. So any exercises that are really, really challenging throughout most of your time, day 1 to 7 is potentially when either peel it back or perhaps don't do that exercise.
Oh, interesting. So that's where you can go from feeling like I'm really strong, feeling really good, then the next week do the same weight or even maybe a little bit less. I'm like, man, I've got DOMs for days.
Yeah.
Yeah, well, I've had that with a few clients. So I'm like, the weight's less. How? Yeah.
And even purely from the perspective of if bleeding, obviously you've got less blood in the system, less of that transport mechanism to get oxygen to the tissue. So obviously oxygenation of the tissue while we train is really important. So like they found that endurance athletes, like they really struggle around that time, simply because like you just don't have as much of that transport mechanism happening, which is just less blood. So yeah, red light around that. It's, again, probably more of an orange light, but I've already used the orange later on, so it just, we'll call it the red light as far as recovery, listening to the body and stuff. And how much is, like I said, different for everybody. For some people, it'll be 7 days where they just need to do nothing. Others will still be able to train, but they just need to factor that in, and basically go based on how the body responds. And it also changes over time. So then from day 7 to 21, so sort of this middle section here, that's when we have our green light. Close to ovulation is typically peak performance. I think it was, I don't remember if it was Russia or maybe a Swedish company, but they were like absolutely stoked because the female athletes had worked out that like the Olympics was going to be around their ovulation, so they basically thought they had it in the bag. I don't actually remember if they did or not win, and I don't know what year it was, but the story is basically just that they were very happy because that's when they had peak performance. And then the day 21 to 28 is when, obviously, we're leading into period. We're getting a bit of a drop off of progesterone, drop off of estrogen. So similar to the period is it's the time to sort of taper a little bit, just listening to the body. If you need to go a little bit less, go a little bit less, but you may struggle to keep up with what you did in that day 7 to 21 window. So just listening to the body, checking in, how's recovery feeling. As you get closer to, I would definitely start to peel it back a little bit. Yeah.
Okay. So if we were to break this down a little further, like the way we look at a regular menstrual cycle is we go, it's 28 days. We start from the day of a period, 7 days, 5 to 7, then it peaks, comes back down. From a training perspective, we should really be looking at like its ovulation phase. First 2 weeks, that's when we should start a new program. You know, we're not doing too much volume, but we're not overloading it through load. Period comes, we reactively deload. Maybe we can keep the same weight, but we still haven't peaked yet. Then that week after, it's game time, peak, let's go, and then reset.
Yeah.
Cool.
Yeah. Bearing in mind
that programs coming.
Bearing in mind that when we say week, it'll really follow Monday to Saturday as we like it to.
No, I'm sorry. Unforgivable. Attention all listening. As of next week, we require Monday to Sunday dialed in menstrual cycles. Yes. If you miss a day, push it a week out.
So yeah, which makes it, I would imagine, slightly frustrating in that if like day 1 and 2 of training in a week, you're going hard, and then day 3 and 4 you have to peel it back a bit and sort of juggling that. But being aware of it will definitely help with long-term goals. And at least for people who aren't sure of why, like it explains that thing of like, oh, that's why I feel more tired and just run down at that time of month and that sort of thing.
Yeah. Yeah, of course. And it's great because obviously, you know, for trainers out there and people that are more active, it's like just being aware gives you the ability to adjust through the week.
Yeah.
Like, micronutrients, great. What about, it's all about the female and the hormonal cycle, but what about the male cycle? I know men don't have uteruses and we don't have periods, though men have hormones. So would they have certain fluctuations as well? Or it's so much minute in comparison to female cycles that it's just more noticeable?
So I am much less familiar with our hormone cycle.
Mm-hmm.
The only thing I do know is that we produce less testosterone as we get older, which is also true.
Outrageous, I know.
Yeah. So yeah, we produce a little bit less. So it's really normal to notice sort of in 40s and onwards to have like a little bit lower sex drive, a little bit less of that sort of get up and grr-ness that we might apply to training. Yeah. So yeah, that's kind of the limited input that I have with that. Essentially, it's something that I do want to come back around to, but in the words of one of the teachers that I have for all of this stuff, men are biologically simpler, and we can get away with a hell of a lot more than what women can, which just means that things impact us a little bit less and we're a little bit stable because our bodies are not trying to divert to then create and gestate a little human person.
Yeah. Well, for someone maybe listening, like if you've gotten this far, congratulations. I'm glad you've stayed on. Though, with that information, would that also then tell us that as a male, it means that I can mess myself up. Like I could eat, stress, sleep, like deviate my sleep for longer, but then it's going to take me longer to fix maybe whatever I've done to myself. But for females, the body's more responsive. So yes, things can change in a shorter time frame, but it means that they can, if they are paying attention, react to get themselves out of there quicker.
Speed recovery. The simple answer is I'm not sure. That's a really interesting question. I think most men and women, the longer you've been doing something that messes you up, the longer it'll take for your body to bounce back, particularly in the sense of hormones. So, for example, a really simple sort of example is that if a woman has been on a contraceptive pill for a long time or a hormonal contraceptive, they are giving their body synthetic estrogen and a synthetic progesterone. So the receptors in the body can't tell the difference between the fake and the real stuff. The body, however, is still getting that hormone. So it's like, cool, well, I don't actually need to manufacture any of this because it's just being given to me. So then coming off the pill, the body takes a little bit of time to then start manufacturing the hormones again. In males, I would expect it's very similar. So that's probably why there's issues with juicing and stuff like that as far as steroids, because that impacts testosterone. But I just don't know about that in males. But I would assume if it's the similar picture, you have the same result.
Yeah. Okay. Cool. What to bring it full circle. So I'm experiencing pain. Feel like my menstrual cycle's a little bit of a mess. I feel a little bit lost. What would be your top 5 tips for someone who's wanting to kind of get back control but doesn't know where to start or go?
So you can definitely start with a GP. If just completely unsure, if you don't have any other health practitioners in your life, because most people have a GP that they know. My caveat with that is that GPs, I think, and the reason I'm so driven in this area, GPs don't get good training in this. And it's a very much one-size-fits-all approach. Whereas I believe, based on the stuff that I'm learning, that it's not one-size-fits-all. It's very much your particular story is your particular story and needs to be treated as such. And there's a bunch of different things that influence it. So it's a thing of, this is our list, and we just slowly go through it together and see what we can change. Whereas in a medical setting, you will most likely be recommended to go on hormonal contraceptive if you're not already, and that's kind of it. And then eventually, we should just give you a hysterectomy. In fact, in gynecological circles, they call perimenopausal symptoms or rather they blame perimenopausal symptoms on just the fact that a woman still has the uterus, because once your reproductive years are over, why would you need it? Just cut it out. Like, it's not serving any function. So it was literally called chronic recurrent uterus. The diagnosis is you still have that organ and we should cut it out.
Oh.
So that is an example of just the less than ideal approach from medicine. And I'm sure that most women who have this stuff have probably had an experience where a doctor hasn't either listened to them properly or hasn't reassured them or given them a solution that they were happy with. Yeah, and again, that just comes down to there's not enough focus in this area and there's not enough evidence, and GPs aren't given that very well. So if that doesn't work, if you're not comfortable with their solutions, my next suggestion would be to find a chiropractor that does women's health, or a naturopath. So they're the two sort of realms that I currently think can probably handle it the best. But you just want to sort of check in first if they do in fact deal with women's health specifically in these realms. And if they don't, then ask if they know anyone else. Or you can always reach out to Karl or myself and we can give you a direction to go in. Because hormone imbalance isn't normal. Symptoms around the period, except for what we talked about, are not normal, and you shouldn't have to deal with them. And they are usually caused by an imbalance somewhere in the lifestyle. So high stress is a big driver. Really poor nutrition is a driver. And then the other thing that is a big component of this is hormonal contraception. So if on contraceptives and experiencing a bunch of symptoms, that's a place to essentially start to consider if coming off it is an option, which it's not for everybody. But if it is, so if you've been prescribed it, not to actually prevent you from getting pregnant, but to manage symptoms, then it's probably doing more harm than good. And coming off it may fix a lot of it. Not necessarily straight away is the key point, because your body will have a bouncing back period of 6 to 12 months.
Yes, I learned that the hard way.
Yeah.
So if you're someone who is having irregular menstrual cycles, experiencing pain, you're wondering what the top 5 tips are with Dr. Luke Ross. Number 1 is find a local GP that you can connect with. 2, if you can't find that person, reach out to Luke, myself, or someone in our team. Got Amy Mason and Kathy O. Number 3 is reflect on stress management systems. Might be something that's not helping or serve you. Maybe start taking 30 deep breaths to calm the nervous system down. I just add that one in. Number 4 is looking at your nutrition, as that may be playing a part, could be affecting the hormones. Luke gave us a list of zinc, selenium, some B vitamins that can help, and iron during your period time. So you may be having a lack of micronutrients, something to look at. And 5 is looking at the contraception that you're taking, changing and slowly transitioning. Of course, speak to your medical professional prior to. And these are things that can help you keep a log, as I would say, maybe keeping a log, so that if you do go through Luke, you have some information to share to get more insight and feel a greater connection and certainty in the path to move forward. Awesome. Luke, it's been a pleasure. I think that is a great way to wrap up for today's podcast. I know I'd be keen to talk more training methodologies and understand, have you poke holes in my thought process with all the research out there and information. So thank you very much.
No worries.
Until next time, everyone, enjoy and adios, amigos. Hey, thanks so much for joining the episode of Table Talk today. We hope you found some helpful tips and inspiration in staying healthy and fit, even with a busy schedule. Be sure to subscribe to our podcast. Stay tuned for our next conversation. Until then, keep prioritizing yourself, your health, your fitness, and we'll see you on the next Table Talk.